the history of a perforated peptic ulcer back in February this year, and she had a laparoscopic patch repair performed at that time, and the recovery was uneventful. An OGD performed in April found the previous perforation site already healed with a 2.5 centimeter mucosal bulge over the fundus. A CT abdomen done in July found a 6.7 centimeter ill-defined mixed solid and cystic lesion posterior to the gastric fundus with an impression of an organized collection with thick rim of inflammatory soft tissue. An EUS done in August found a loculated collection at the superior wall of the stomach separated from the spleen, and FNA yielded 30 mils of pus and collection collapsed afterwards. A follow-up CT done in September found a similar size thick rim collection suggestive of a recollection. So here are the OGD and CT findings, and today we will perform a EUS-guided drainage of the intra-abdominal collection.
Hello.
Shannon.
Hi, good afternoon, Shannon.
Oh, hello, Dr. Lee. Hello,
Hi.
Professor Lau. So I think you've heard the history. So this patient had a previous patch repair done before and somehow have a collection at the posterior wall of fundus. So can you see the EUS view?
Yes, we can.
So this is actually the spleen here. And the collection is right here. So on EUS, it actually looks smaller than the CT scan. So this is the view where I can find that it is the largest. So it's only around 2.6 millimeters.
Do you think it will disappear on conservative management?
Sorry, I cannot hear you.
Do you think it will disappear?
You mean without
Just watching?
treatment?
Yes.
So last time we did an EUS aspiration, and I did it last time. So I think I thought I completely aspirated the collection, and then on follow-up CT scan, the collection came back. And that last time, I think I aspirated about 30 mils of pus, and the culture was positive. So. And on CT scan, the size actually the abscess completely recurred. So we thought maybe the patient needed a EUS-guided drainage. So what do you think?
How do you explain the recurrence?
As you can see on EUS, it's actually quite a walled off.
Right, but then you aspirated it dry last time, and then it has come back.
So could it be it has a capsule right here? So I'm not sure if that is why it recurred.
Hear me?
Okay.
Can you hear me?
Could there be a good?
Yeah. So I think one of the possibility is actually there might be still some food debris or dirty material inside that was not cleaned off. So. As a result, there's a recurrence of the collection. What do you think, James?
No, I'm just concerned that there might be an occult fistulation somewhere.
Fistulation to the duodenum?
Well, I don't know. It would be most unusual because this is in the back of the stomach and next to the splenic hilum.
Can we take a look on X-ray the location?
It's okay. You carry on. I'm just concerned. Could this be a peripancreatic type of lesion?
But last time we aspirated and it was pus.
Did you check the amylase level?
We did not last time. So
I think last time the presentation was more compatible with a post-op collection. So we weren't suspecting a pancreatitis, kind of like a.
And pyloric perforation. If there's a leak, then it would have gone to.
It should be around the duodenal area and not so far away. Can we X-ray? Have a look at the location.
So what would be your plan? You want to put in a plastic stent or metal stent, or just repeat the aspirations?
So before when we were planning, on the CT scan, the collection was actually 5 times 6 centimeter. So the initial plan was for the hot spexes, so that we can drain it and even to put a scope in and irrigate the collection. But now on EUS, the collection is only 2.6 centimeter. So technically it's still feasible for the hot spexes, but it may not be worth putting in a metal stand for a small collection.
Do you think there's some material right there? There's some just now I saw some ecogenic material.
Here?
A bit more? Yeah. Is that a clip or something? Or
But I don't think they use metal clips for laparoscopic patch
I don't
repair.
know. It feels like some material there.
But why metal clip would be on the splenic side with a perforated peptic ulcer?
I don't know.
It's all very
Very
unexplained.
postulation, yes.
So Tonggo, what do you think? What would you do if you were me?
I'm not so sure for this small abscess. I maybe just repeat the aspiration and see how it goes.
Okay, let's try to aspirate, see
Yeah,
if
we
we
can
can
go.
aspirate anything.
If we cannot aspirate because of the very thick pus, then we may need to put in 1 or 2 plastic stand to increase the drainage.
Oh, 唔使喎。我哋講緊 negative suction。好啊。
So what needle are you using, Shannon?
So this is a 19 gauge EC shot needle that I'm using. So first, before we puncture, we check for any blood vessels. Seems there is no major blood vessels that is
So is this your usual needle?
For interventional, so for example, if you're contemplating for pigtail insertions or stent insertions, 19 gauge EC shot is the usual needle that I would use. So here we are.
So YT, which needle do you usually use?
Same, 19
Same,
gauge
any
needle,
gauge,
yeah. And any brand would be fine.
Okay, it's very difficult to puncture.
Seems like it's very thick. The wall is
Yes.
very hard. Huh?
好勁啊！ I also remember last time it took a bit of effort to get the needle through.
Yeah.
Oh,
So this is a 19 gauge needle, nitinol needle. Nitinol is important because
okay.
it's more flexible. This in very odd positions, the needle can also be passed out.
Suction 啊！
In the past, when we used a stainless steel needle, it's a bit difficult to push out when we puncture in the duodenum or do some theory interventions.
Yes, for the fundus, the scope need
tissue.
to be
唔知道。
tilted up a little bit, very difficult to use the force to put the needle in. Can you aspirate anything?
A little bit of blood is coming out, so I'm adjusting the position.
I think overshoot a little bit, so she's readjusting position. I think your needle is out already, right?
No, not really. I think it's there.
Just a little bit. I think you probably need to repuncture or something.
Hey, this is a better site.
And actually, I think you have suction some of the tissue up to your needle tip. That's why you blocked off your needles.
No.
So what are you looking for, Shannon?
I'm looking for a better site to puncture because this is, as Dr. Lee has said, part of the wall is suctioned up.
Probably difficult to avoid.
Okay, so maybe here. 好，我哋開一開鏡啊。
I saw some most aggressive method to treating this connection is by Dr. Liu Bingyong, that he actually just create a hole between the stomach and the connection.
With,
He calls it fenestration.
with him, I think he does everything in the Nook's way, right?
Okay, so I think I've repunctured, and I think in a better position.
Yes,
so
yeah,
let's
better
see,
positions.
Let's see if anything comes out.
So
I think there's
we
something coming out, is it?
we see some blood-stained pus, is it?
Not staying with
It's still blood stain. We're still seeing if there is pus. But I think I'm in the collection, so we just need to wait a bit.
I think something is coming out.
So now we try to empty the connection, see how far we can go.
Yeah.
Yeah, the pus is coming out now.
Okay.
有冇第二個? So what do you think? I think this collection is actually collapsing on aspiration, and it'd be difficult to put in anything actually.
Well, I think we can try one more round of aspiration. If this time it still recollects, then we have a better reason to place a larger caliber stand.
Okay, if the pus is too thick to aspirate, would you ever irrigate it with saline and then make it easier to aspirate? Would you do that?
I guess we can, but if it is very difficult to aspirate, sometimes putting in a plastic pigtail may be just a once and for all treatment method. So can you see the pus that is coming out here?
Okay. So
Well,
you
sometimes-
decide to just aspirate now, isn't it?
I think for this time, probably just aspirate, and we'll see how the patient goes.
Okay.
Sometimes I will irrigate with saline, similar to like pancreatic cyst. So if the mucinous fluid is very thick, we can add some saline and try to dilute it and make it easier for aspiration. So, and sometimes I would add saline so that we can get some material for culture.
Exactly. Okay. So you continue, Shannon, and
Okay.
then we go back to room 3. Hi, Dr. Chan,
Hi,
what
Dr. Lee.
are you doing now?
I actually punctured the third time because the second time we yielded 15 mils of pus, and then it stopped coming out. So I repositioned and repunctured, and now there is about 10 mils of pus in the syringe. And you can see on EUS view that most of the cyst has actually, or the collection has collapsed. So I think this will be the final puncture. So
you're not going to irrigate it?
in the middle, we actually irrigated once.
Oh, okay.
Yeah. I think after we aspirate dry the collection, we'll probably just go and follow up the patient with a CT scan to see if it recurs.
So what would be the size that you would prefer to insert the stent? What is the minimal size that you are comfortable insert the stent? Like plastic stent, for example.
I think normally, for example, for walled-off necrosis, I've done 3 centimeter collection, but those are very indicated for drainage because the patient was septic. So for this case, I think it's technically still feasible, but just clinically not very indicated for putting in a metal stent for this patient because she's actually clinically asymptomatic. So we probably will leave it for next time. If it still recurs and we have more indication and reason to do a more invasive drainage.
Okay.
仲有少少時間，仲有8分鐘。
So it's still coming out. So I probably will be here for some time.
Okay, we'll go back to Philip.
Thank you.